Thank you.
Afternoon, everyone. Welcome to the Care and Health Informatics, or CHI themes slot for today. For those of you who don't know me, my name is Pete Dixon. I'm a researcher based at University of Liverpool within the theme. And in a little while, you'll be hearing from Sarah Rogers, our theme lead. Before we start, however, I think it's fair to say that we are very aware within our theme that we are somewhat a FOCA, and you'll agree. I'm sorry, there's some blank looks. I should have said it stands for excessively fond of confusing acronyms. So Peter Lloyd, our co-lead, will probably say that it's sometimes like drowning in a bowl of alphabetic spaghetti with us. So we've tried to keep it to a bare minimum today. So here's the plan. So once I've finished speaking, I will actually carry on speaking, but as a sort of disembodied voice, to a video talking about the benefits of household data linkage in health research. We're indebted to Darren and Sean, our comms team, for helping us put that together. And then following that, Sarah will be speaking to you in a pre-record around a project that's used household data linkage, specifically looking at green and blue space and its effects on common mental health disorders within the population, which it fits in very nicely with our theme today of mental well-being. That'll leave us a couple of minutes, hopefully, for some questions, and even more, hopefully, some answers to those questions. And then you will be delighted to know that it is lunch. So without further ado, I think if I click this, it's time to run VT, isn't it?
Hello, everyone. Today, I'm going to talk to you about the benefits of household data linkage in health research and how this can be used when working with NHS and other data to work out why people become sick or poorly in the first place and how people are influenced by their social and built environment, the so-called wider determinants of health. After all, people may be sick whilst in hospital, but they generally didn't get sick because they are in hospital. It's the preceding events that led to them being there. We believe that harnessing the ability of household data linkage will provide a step change in allowing providers to generate stronger evidence-based policies to improve the health and well-being of all individuals in the region. Often, analyses are made and results reported on an area-based approach, such as electoral wards. Whilst this is informative and useful in targeting resources and interventions, there is a risk that the results may wrongly attribute average population characteristics to individuals within the population, what is known as the ecological fallacy. But there are other benefits too to linking data at the household level. The population of an area isn't static, people move house. Having household linkages that are dynamic will allow cohorts of people to be created over time. When analyses are restricted to small area geographies, these do not allow the ability to check if one group of people have been replaced by another group who may be more affluent and healthier, so-called gentrification. Individual household level cohorts would allow an assessment of whether people have truly improved health as a result of service improvements, rather than simply being different people. Household linkages allow analyses to be undertaken to assess whether a change in environment impacted health, rather than it being the case that people who were more affluent chose to live in a greener and more pleasant location. This more robust evidence is liked by the Department for Health and Social Care, as it enables an examination of whether the exposure came before or after a health outcome. Household linkage also enables the construction of household groupings containing people who are likely to be members of the same family. This could, for example, enable inference of whether a child's health is impacted by that of a parent who suffers from their own health condition. A household linkage table will also allow researchers to flag only those who received a service, rather than include everyone in an area. Including everybody is a background of noise that is likely to drown out any signal of the population health benefits of a service. Analyses at the household level would therefore give evidence to help prevent services that are effective from being stopped and prioritise services more effectively. Residential linkages allow additional environmental data to be analysed into an individual's health record. This could be additional useful explanatory variables, such as distance to travel to a GP, hospital, or community-based clinic, to help understand utilisation of services. Or data could be created for the purpose of adding exposures or treatments to evaluate the population health impact of local policy changes in the wider environment. Examples include changing densities of alcohol and fast food outlets, improvements to active travel infrastructure for each household, and housing quality improvements. So, how do you go about making data linked at a household level? Well, the key to this is something called the Unique Property Reference Number, or UPRN for short. The UPRN is the unique identifier for every addressable location in the UK. You can think of it as being like a national insurance number, but for physical objects. This authoritative code can then be used to create connections between different sources of information that share a common characteristic. And that common characteristic, in this case, is the location. It is possible for people to be linked to a UPRN by their address. That address can be held, for example, in their GP data or other health and social care data. From this, it is possible to create an anonymised household identifier, meaning researchers cannot identify the house. This anonymised household identifier can then be used in conjunction with an anonymised individual linkage field that will be used to link data containing information on aspects of an individual, for example, health, social care, or education. I tell you what, why don't we have a look at a hypothetical example? Here's Joan Brown. Joan lives at number 8 Station Road in a small town in Cheshire. Joan is 72 and, according to her GP records, has chronic heart disease and had a knee replacement 3 years ago. She also gets Meals on Wheels from her local social services. And here's Lawrence Brown. He also lives at number 8 Station Road. Lawrence has diabetes and epilepsy, and he too is in receipt of Meals on Wheels. The Browns have a bus stop at the end of the road. There's a park half a mile away, which they like to go to walk the dog. And their GP surgery, which they attend quite frequently nowadays, is a little further. Now, this information is, as it stands, identifiable. We know it's Joan, we know it's Lawrence, we know the street they live in, and their house number. But when it goes through the anonymisation process, the researcher can't tell who this information comes from or which house and street it relates to. You can see here that Joan and Lawrence have different individual linkage fields. Remember, this links to their individual level data, in this case, medical and social care. They have exactly the same household identifier, though, because they live at the same property. And their environmental metrics are the same, because these also relate to their home address. Maybe the Browns would not have needed so much treatment if the GP was closer. And we can use data such as this to predict if they would have had better health if they had accessed primary care more frequently 20 years ago. Or we could use these data to show where services should be placed to avoid creating further health inequalities. Creating household linkages is quite a hard exercise to undertake. I mean, data is often messy. However, despite it being difficult, undertaking all this is possible. And within the North West Coast, initial steps have been taken. Work's currently being done by members of the Care and Health Informatics and Improving Population Health teams as part of the System P programme to identify complex households, i.e. those where there are multiple members of the same household who are recorded as having specific health issues. Public health is about healthier environments for all, but especially for our most deprived populations who are seldom heard. And by using big data, we can ensure that they are in our analyses. We believe that only by ensuring the facility to undertake household level data linkage will it be possible to use the rich source of health, social care and other data to enable the newly created integrated care systems to deliver on their 4 key aims, namely, improving outcomes in population health and healthcare, tackling inequalities in outcomes, experience and access, enhancing productivity and value for money, and helping the NHS to support broader social and economic development.
Hello everyone. In keeping with today's theme of mental health and well-being, I'd like to share some results with you from a big data study. So I'm Sarah Rogers and I'm the theme lead for the Care and Health Informatics theme in the North West Coast ARC. So we use data that are routinely recorded by the GP from patients, and we use them in this study for our secondary research purpose. And using these health data that are recorded several times each year allowed us to bring in a temporal element that moves us towards causality, which is a more robust study design that is liked by policymakers and the Department of Health and Social Care. So we asked, is exposure to green and blue space associated with preventing people from developing common mental health disorders. And the word that I've written in the title here, subsequent, is important because we set up the study to make sure that the timings of exposure to their environment was recorded before the GP recorded a diagnosis of symptoms of anxiety or depression. So how are we measuring green and blue spaces? Well, my colleagues created a few different measures. We first had an ambient exposure to greenness very close to home. So this was the amount of vegetation seen from the front door. And we collected this from satellite imagery. This is an important and appropriate measure because we don't need people to go into the space, the green space or the park, for instance, to benefit their mental health. They just have to see it from their home and close to home to potentially feel restored. So then we used Ordnance Survey map data and counted both green and blue spaces within a distance of 1,600 metres or a mile. We thought we'd see if we could model how people might go to their local parks and ponds more if they lived closer to them. Just to impress on you that this really is a big data study, we had a decade of following up people's healthcare use. And because this was for more than 2 million adults, this resulted in 19 million person years of follow-up. Our results showed that there were fewer people reporting anxiety and depression to their GP if they live in greener areas. We saw that being able to view green space close to home was associated with a 20% lower odds of developing anxiety and depression. So that's a reduction of a fifth, with fewer people going on to develop a CMD. Second, we showed that more accessible green or blue space in the larger 1 mile distance was associated with 7% reduced odds of anxiety and depression. Finally, for this analysis, looking at differences between people and subsequent mental health, we saw that there's a potential echogenic benefit to mental health from living in a place that has more potential access to green or blue spaces. There was a larger protective effect in the more disadvantaged areas. So for people in areas that generally had fewer resources overall, there was more benefit from their available parks, lakes, and outdoor nature trails. This study had several strengths, and it's a step forward because first, we most definitely have the exposure first and then the health event. And this often isn't the case because the amount of green or blue spaces that people experience at different times, their exposure, is often not recorded at the right time. We could do this because we could look anonymously at the individuals and update their green and blue exposure when they moved home, thanks to the household linkage mechanism. Second, we included large numbers of people, so there was no selection bias in whose data we had. We had nearly everyone's data for all adults in Wales, 2.3 million. We had the environmental data at the household level rather than at small areas, so reducing something called ecological fallacy. And this is really important over the 10-year follow-up time in our study, because if an area is improved, then we'd like to know that we're measuring the same people and not just the new people who have moved in because it's been regenerated and the original people have been displaced. We had some limitations too. We still have differences between people, so we cannot rule out self-selection. In this larger study with millions of homes and people, we did not have any behaviour, activity or GPS data, which are really useful. We used records of people seeking help from their GP, and this is much better than only having hospital admissions, but we didn't have well-being measures. So these data could be considered rather a blunt outcome measure. And I think this is especially true because we know that another 30% of people live in the community with anxiety and depression, but don't seek help from their GP. This study was set in Wales, but we've since been commissioned as part of a new large project called Groundswell to work with Liverpool City Council using data held in Cheshire and Mersey to characterise the access to green and blue spaces for the wider city region from Wirral through Knowsley and Sefton. So we'll be looking at not only mental health, but setting up our data to look at conditions that might be impacted longer into the future, like cardiovascular conditions. We're currently working with Wirral Council and the Liverpool City region to make sure that new parks and transport are designed with all of our residents' needs in mind. And to that end, we've got several public advisors from the Arc North West Coast who are helping us with this. So we want to use the big data to evaluate, but also collect survey data to add well-being and behaviour data that aren't routinely recorded. Bringing this full circle back to where Pete began. This means that it's important to have the mechanism to create household linkages so we can add to each home the distance to the nearest park, for example, so that we can evaluate the changes and make sure they are improving health and reducing health inequity. Thank you very much for listening today, and the CHI team and myself will be very happy to answer any questions.
Cheers, thank you very much. So we've got about 3 or 4 minutes, I think, for questions before. That's it's not Sarah live, is it?
It is.
Sorry, no, you did that without moving your lips, Sarah. That's very impressive.
I think I've frozen. Yeah, I'll stop my video.
What's that fellow with that nookie bear? We've had one question online, which hopefully Sarah or Ollie may be able to answer, which is how do you minimize? God, I need glasses. How do you minimize the identifiability of individuals when you use a unique property reference number? Household makeup is much more unique than an individual with a postcode. Sarah?
So. Yeah, so Pete, thanks, and is it Hayley asked that question? Yes, Hayley. So yeah, thanks for that question, Hayley. I think that you would probably, when you see the data in the table, like the one that Pete showed, you really can't have any identifying characteristics, because it would just be a lady at 72 years old, like Joan, and a man who lived in the same house. So there's nothing really identifiable out in that data. However, all the data are secured anyway in a data bank, and trusted researchers can access those data. So we're all accessing the data with the promise that we won't try and re-identify anyone, and it's very hard to do that anyway. So yeah, it's I can see your point that they are more unique, but we do the research without ever knowing who they are or where they live. It's an anonymized residential household linking field that we put onto everybody. So we make sure the people are nested in the houses, but we can't tell which house it is. We don't have any location data on the house at all. So I hope that helps.
Cheers, Sarah. Is there any questions? Yes, just here.
Thanks. I'm an architect and I'm really interested in this project. One of the places you showed was Blackpool. I'm just wondering, how do you imagine making Blackpool a greener kind of place for the residents?
Sarah,
yeah,
do you want to...
I can come in here, Pete. Yeah, that's fine. Yeah, thanks very much for the question. I think with Blackpool, it's it does look quite grey, doesn't it, at certain times of the year, but it has got that lovely blue space. And I think with working with our local public advisors, we can introduce some small scale green areas, like even if it's window boxes and tree planting, that would really help and lift people's spirits up, and maybe community gardens if we identify some spaces for those, working with our local communities. So I think that is the way to go with that.
I think we got one more from Neffin.
Yeah. Hi, Sarah. That was really interesting. Can you tell us, did you say you were going to include some behavioural measures and measures of people's activity?
Yes, yeah, we'd really like to do that. In fact, in another part of the same study, we did link together with the routine data responses from people who filled in a survey, and it was a national survey for Wales. So we had about 6,000 people who actually gave us quite detailed information on their deprivation and their well-being. And there's another part of the study that I haven't presented today that has all that information as well. So that is really valuable. And we're trying to set up a data set in Cheshire and Mersey and the wider region at the moment that will actually have that function to link the behaviour data from individuals who consent to have their data linked into the wider routine data sets. So hopefully we'll have the best of both, in that we'll have some very detailed data for individuals, and then we'll embed those into the sort of the wider population health data as well.
Thanks, Sarah. I think we've got one more question, Peter. Have you over on the left? Cheers, sir. Oh.
Yeah. Show the feedback. Just very quickly. I'm part of this team. I'm a privileged part of this team. I'm the PA co-lead. This is the thin edge of a big debate that's going on, and I don't think we should leave it without making sure this is the case. We're about to get things called secure data environments, and the whole thing about this, and that's important to every one of us, is that you get the best out of it by the balance between confidentiality on the one hand, ensuring that people's private data doesn't go to the wrong places, and the freedom for researchers under very controlled conditions to be able to get the sort of thing you've just heard about. And the beauty of it, as Pete's presentation showed, is if you could have that data and people trust, that's where the word trust appears. It started as a trusted research environment. If people can be persuaded to trust researchers, then the amount of gain that we can get in terms of what we need to know for well-being, health, and so on. So it seems to be a message that needs to go wide, which is why I've intervened here. That people should be encouraged to take the view that, yes, their data should be secure, but that they don't want to be overdoing it to the point at which it kills the benefits for population, society at large from what can be done in here, which is enormous.
Very well said, Peter. Thank you. Can I just come in and sorry, Pete, I just want to mention, as just following on from what Peter said, there is this secure data environment bid. We've got funding from for the NHS England, and we want our public advisors to have your say in how it's set up. And so we're going to, I think, try and get you involved in a focus group to make sure that our public have a voice in the governance and the NHS secure data environment. And that's for Lancashire, Cheshire and Mersey and Manchester as a whole. So look out for more information and invitations to that. Thank you.
Cheers.
Last question, because people can smell lunch and we're running over.
Can you hear me? Yeah. Mine's just a comment. From the days of Clark and ARC, public advisors have been out talking to the public, and we've always had something called a wish tree. We found that on this wish tree, every age group, but more so the younger population, all they want is greener spaces. So that's all the wishes that are coming through from them. So, you know, you talk about asking the public advisors and researchers, but we're already getting this message from actually the younger generation.
Great point to end.